Welcome to the AATS Mitral Conclave 2017. I'm Dr. Randy Martin. I'm thrilled to be joined by Patrick Perier, who's well known, tremendous contributions, just gave a fabulous talk. So Patrick, I want to shift gears a little bit. Tell me, what do we know about minimally invasive surgery versus the conventional approach for mitral valve surgery?
So we know that minimally invasive surgery has started about almost 20 years ago.
Right.
And we know that we did a lot of progresses throughout the years, and that at least in Germany, as you may know, 50% at least of all isolated mitral valves are repaired minimally invasively.
So when I use the term minimally invasive, what am I talking about? Am I talking about right thoracotomy? Am I talking about robotic endoscopic? What am I talking about?
Okay, there is a definition apparently of minimally invasive, which is everything that is not through median sternotomy is minimally. But I agree with you that minimally invasive, in fact, is a spectrum of disease, a spectrum of intervention, excuse me.
Okay.
You can do minimally invasive surgery with a big incision, so right thoracotomy, or you can do minimally invasive with a robot, or you can do minimally invasive like I do with a very small incision around the nipple. And everything is called minimally invasive.
So are the instruments dramatically different?
The instruments are dramatically different. I would say that it's different in the way that it's a new type of surgery.
Sure.
And you need to train, you need to be exposed, and you need to learn, as if you would need to learn a new technique.
I'm gonna come back to something, but you triggered me. So, does the surgeon who wants to do minimally invasive need to have a lot of conventional surgery experience, or the young surgeons now are just learning minimally invasive out of the gate?
I guess that if a young surgeon is trained with a surgeon who is performing minimally invasive surgery, he will learn to do this minimally invasively. And in fact, it's a much better way to train people, because you are obliged to look through the camera, endoscope, and you have a very good vision. So the trainee has a good vision of what you do, but then when you assist the trainee, you also can control much better what he's doing than through sternotomy.
So you're saying that it's really not necessary for a minimally invasive surgeon to have had extensive open sternotomy experience?
No, you can't do both at the same time if you are trained by someone who is an expert. When we started, if you start to build a program by yourself and go through in the unknown, then you have to have a good experience of the mitral valve to start to do minimally invasive.
So we talked about it, the patients, obviously, consumers they're thinking they want minimally invasive. Do we know now that the outcomes are as good? Repair rates, strokes, hospitalization, there are many advantages that people talk about, but are the outcomes the same?
So when we started, we had one objective. We wanted to have the same quality of the result, and we wanted to have the same security and safety.
Okay.
So
absolutely.
we concentrated on this, and we concentrated on the controls of our results. And so far we can say that we can achieve 100% of repair minimally invasively.
Okay.
And we can say that our operative mortality is 0.2%.
Okay.
And if we take only asymptomatic patients, it's 0%.
Okay.
We can say that 92% of patients at discharge have zero or traces of regurg. We can say that the rate of stroke is 0.2%.
Okay.
And we can say also that something which is very important, the need for blood transfusions is dramatically reduced.
And obviously, do they go back to work faster? They go back to their normal activities?
They go back to work faster. And just to give you an example, there are patients, not all of them of course, but they would come to you after 1 week and say, "Oh, doctor, I'm exactly in the same shape as when I came," which is remarkable, and you would never see this with
So Patrick,
sternotomy.
you're selling me on this. Why would anybody want to do a conventional? Obviously, if you're not doing concomitant other valves or bypass, but why would anybody do a conventional surgical approach?
I don't know. I don't know. A patient would come to me and say, "I want to have a medium sternotomy because I know that you see better." I would do my best to convince him to have this done through minimally invasively. It's now we are this far. At the beginning, we have found all the excuses not to do. Yeah.
So is there, and I asked you this before, I just want to hear it again, is there nothing you can't, if conventional surgery, you could do everything, conventional sternotomy, you see everything, got great exposure. Is it the same with minimally invasive, or is there anything where there's a limitation of the technique?
It's exactly the same. I mean, we can do the same. And in our beginnings, I said we wanted no compromise in the quality. It means that no compromise in the techniques that you are using. There is only one exception that we do through sternotomy, is when you have those big bars of calcium of the posterior leaflet, because the instruments are too fragile. And
obviously, if you're doing other valves or doing complicated cabbages or things like that, right? So the selection is really for patients with
mitral and eventually associated tricuspid.
Eventually, so we're not there with tricuspid yet.
We do. We can do. We can do associated tricuspid. We can do mitral tricuspid ablation at the same time.
In the future, say in Germany or worldwide, do you think there'll be more minimally invasive approaches than conventional sternotomies?
I think that progressively there is a shift, that there is more minimally invasive surgery. If you see in Germany, every year it's minimally invasive is gaining. I think that we in Germany probably are the most advanced in this. But I think that in Europe, at least, in other countries, it's coming. Everybody's being very interested in this because for the patient, the advantages are numerous. Yeah. There's no doubt about this.
Cost the same?
Cost is probably less. It has been shown in some studies that the costs are less.
Because of hospitalization.
Because of hospitalization, right. Okay. Because of blood products, because of faster recovery.
Well, you've given me new insight.
I'm glad.
Thank you very much for joining us. And thank you for joining us. I hope that you'll come back.